Hey, Rob Fitzgerald again. Thanks for tuning in. I've got 8 slides to explain the coagulation cascade. Yep, 8 slides and we'll be done coag. So just a quick overview. I'm not a hematologist or a coag person. I'm a clinical chemist, but I'm going to give you some of the basics. So let's get started. So hemostasis, stopping blood from stopping bleeding essentially, is tightly controlled through a couple of processes involving platelet plugs. So platelet plugs are necessary and they're the beginning. That's where the rest of the coagulation cascade starts. They also secrete thromboxane A2, which is a vasoconstrictor. We're trying to decrease blood flow to that area so we have less chance of bleeding. And then we have a coagulation cascade, and that's a complex system of proteins that act on each other. There's a bunch of amplification steps that we'll talk about, and there's also some moderating effects. So some effects to try to keep that coagulation limited into the area where you have tissue injury. So as we said, the platelet plug is the necessary precursor for a fibrin clot to form. It happens when you have tissue injury. Circulating platelets in the bloodstream recognize that tissue injury, and they stick to the subendothelial matrix. And they stick in 2 different ways. You have a factor called von Willebrand's factor that they stick to, and they also stick to collagen. Many of these steps have, duplicative processes, so if you're deficient, you don't automatically bleed out. It's just from evolution. So platelets bind to von Willebrand's factor through glycoprotein 1b95. And so all of these glycoproteins get a little bit confusing, but essentially it's sticking to von Willebrand factor. And as we said, it also sticks to collagen through 1a2a. And so those are necessary coagulation factors in order for that platelet to stick. So they adhere and then they aggregate. And so they aggregate because platelets express or attract glycoprotein 2b3a on their surface, which binds fibrinogen, which attracts other platelets. And so it attracts and activates other platelets. And so the last step is they're activated, they're secreting things. ADP, thromboxane is the vasoconstrictor that we talked about. They also synthesize and display factor V on their surface. And so factor V is an essential component of the coagulation cascade that we'll talk about in just a second. But all of these things are initiating the platelet plug and then followed by coagulation. So here we have the tissue right here. This would be the bloodstream side, and we have these endothelial cells. And you can see we have a damaged endothelial cell, and platelets recognize that, and they're going to sort of try to plug that hole, and they're going to do that by binding to both collagen, which we have in the tissue, as well as von Willebrand factor, which is circulating, that binds and sticks through GP 1b95, so a complex of coagulation factors. So that's the beginning of it. The platelet also, on its surface, expresses 2b3a, so those are more coagulation factors, which binds to fibrinogen and allows platelets to aggregate. So the platelet aggregation, again, is trying to really essentially fill this hole where we have a leaky endothelium. The last step is they activate and they start to express factor V on their surface, and that's going to be an essential component of the coagulation cascade, which is essentially prothrombin to thrombin, fibrinogen to fibrin. And so we'll talk about the coagulation cascade next. So the coagulation cascade, as we said, the platelet plug is required, so we have to have a platelet plug for it to get started, and once we have that started, the whole coagulation cascade is really trying to form a fibrin clot so that we can prevent bleeding. And so we'll go through the steps real quick. What happens is when the endothelium is injured, it secretes a factor called tissue factor. Tissue factor is then going to act on circulating factor 7. Factor 7 is then going to be activated, and it's going to activate 10 and 9. 10A binds to 5A, so 5A was already on the surface of the platelet. That's what we talked about in the platelet plug. It binds to 5A, and then that's going to start the conversion of prothrombin, that's factor 2, into factor 2A, which is thrombin. 2A, thrombin is going to convert fibrinogen into fibrin. Fibrin is going to polymerize, and it's going to get cross-linked by factor 13, which forms a stable clot. So that's essentially the coagulation cascade. There are important backup and amplification steps. So many of these steps have duplicative pathways to ensure that we get good coagulation, because obviously from an evolutionary standpoint you don't want to be bleeding. So important ones, if you lack these amplifications, so as a chemist I look at it and I say, well, you've got 10A, you got 5A. Why do they have a bleeding problem? Because that's going to activate 2, which is going to activate 1, and you're going to get a fibrin clot. These amplification steps are really important, because if you don't have them, you don't get the robust response when you have a tissue injury. And so if you lack these amplifications, you do get bleeding. Common diseases would be hemophilia A, which is an absence of factor 8. Factor 8 is really just an amplification process. It's just going to amplify the 10A, 5A, which is going to cascade down into a better fibrin clot. Factor 9 is also purely an amplification step. And again, if you have a deficiency of factor 9, you get hemophilia B, and both of those are fairly common bleeding disorders. So we've got the coagulation cascade, we've got amplification steps, and we've got moderating effects. So we want to localize that coagulation to the site of injury, and we don't want to have disseminated coagulation, because then you're going to be forming clots, and you could occlude arteries, etc. Or you could just deplete your platelet supply, and then when you do have injury, not be able to respond. So the moderating factors, thrombomodulin, so factor 2 is prothrombin, and so it's going to cause factor 2 to activate protein C, which works with a protein called protein S, which feeds back to inactivate 5 and 8. And so 5 is that essential step on the platelet that it combines with 10 and activates 2. So this is going to, again, moderate and localize that coagulation to the specific area of interest. Other moderating factors would be antithrombin. Used to be called antithrombin 3, and it works on heparin. Heparin is the same thing as heparin, except that it's endogenously available. So heparin primarily binds to factor 2, but factor 2 amplifies some of the other steps, and so it has a more of a complex role. But anyhow, it acts to limit the coagulation, limit the spread of coagulation. Factor 12 activates plasmin. So factor 12 is also an activating and an amplification coagulation factor. So it actually works through the intrinsic pathway to amplify through 8 and 9 back into 10 and 5. So it's also acting directly to activate plasmin. Plasmin breaks down fibrin clots, and so again, this is going to help localize into that specific area where you had the tissue damage. When we break down fibrin, we form a product called D-dimer, and D-dimer is a clinical test that we use to look for coagulation, and especially disseminated intravascular coagulation, DIC, where you're going to get a lot of D-dimer formed. So here's our picture of hemostasis. So we start out with circulating von Willebrand's factor, recognizes the tissue damage. Platelet's going to stick to von Willebrand's factor and to collagen. It's going to express factor V. It's going to cause the platelets to aggregate. This damaged tissue is going to release tissue factor. So tissue factor cleaves factor 7 to factor 7A. Factor 7A activates 10, which is bound to 5, and so 10A, 5A is a really important complex because it activates, it cleaves prothrombin into thrombin. Thrombin then acts on fibrinogen, which is factor 1, to form fibrin, which forms a fibrin clot. Factor 13 cross-links the fibrin clot, and so now we have a stable clot. And so that's the desired endpoint of the coagulation scheme. So moderate or factors that are going to amplify, 9 is amplification. So 9 is going to work through von Willebrand's factor and 8 to activate 10A and 5A to amplify this process and get a better fibrin clot. Factor 12 is sensitive to a negatively charged surface, so damaged tissue has a negative charge. 12 activates 11, 11 activates 9, and down through that complex. So if we have a deficiency of 8 or if we have a deficiency of 9, we have hemophilia A and B. So without those are important amplification steps. So the amplification is also quite important, not just the primary driver of 7, 5, 10, 2, 1 to fibrin. On the modulating, so to localize, factor 12 also acts on plasmin so it activates plasminogen to plasmin, which breaks up the cross-linked to form D dimers. And as we said, we also test for D dimers. Heparan is also in circulation. It binds to antithrombin, sometimes called antithrombin 3, and that's going to inhibit 2A and 10A. So essentially it's stopping here and it's stopping here. So this is going to it's very similar to how heparin, the drug, works by acting on factor 2. Factor 2A is also an important amplification. It's also feeding back on 11 and 8, and so all of these pathways get sort of complicated. The last moderating effect I want to talk about is thrombomodulin. Thrombomodulin acts on 2A to cleave C to activate protein C, which combines with a protein called protein S. And this complex of C and S inactivate 5 and 8. So it's feeding back here to limit again. It's a modulating effect. So we've got the primary cascade, we've got amplification, and we've got moderating effects. And that's really a quick summary of hemostasis. Thanks for tuning in.